Colleagues, good afternoon. I think the microphone is too loud. I think that this session is very relevant. When we are speaking about the prevalence, incidence and mortality, of course, colorectal cancer occupies one of the first positions in this chart. I would like to remind you that CRC is second in terms of mortality of cancer. Speaking about incidence, it occupies the third position. So we understand that it is crucial to identify tumors of colon in time, because the earlier the diagnosis is established, the more probability there is to preserve the life and health of the patient. As of today, in early cancer, if there is early cancer in rectum, we can use microinvasive surgery. If there is early cancer identified in sigmoid colon, so there is the possibility of submucosal dissection. If cancer is accompanied with metastasis, it will cost a lot and the prospects of the cure are lower. I would like to invite here my colleagues. First of all, it is Linda Rabenik. She is probably the most experienced expert in the organization of screening of CRC. She represents Canada. Linda, can you please come on stage? Now I'd like to invite Professor Viktor Veselov. So Viktor represents Moscow and the National Coloproctology Center. Alexey Veselov also represents the Coloproctology Center. We also have here the fantastic organizer of various colonoscopy and colorectal cancers organized in Yaroslavl. It is Sergei Kashin. I cannot see him. And of course, Moscow is also represented here by Irina Korzheva, who is head of the endoscopic department of the City Clinical Hospital named after Botkin. I don't know, how shall we proceed? Are our presentations ready? I haven't been informed about any postponements of our session, but apparently not all the speakers are present yet. So I guess that we can still go on, since we have already started our session. Recently, there was a candidate PhD thesis on submucosal dissection that was defended. And we have here the two opponents. Irina, who was the opponent, and she is here today. During that event, we discussed those technologies in detail. Evgeny, we are happy that you have joined us. I have to say that, of course, such technologies are not yet widely used, unfortunately, especially if we are speaking about microinvasive radical treatment of early cancers. But at the same time, I am convinced that even if there are many such patients, I think that these technologies will be more and more widespread. I'm sure of that. Still, we have some centers that have experience in such interventions on rectum and in localizing tumors in middle intestine, and the prospects are quite promising. I am dreaming of getting the technologies that was developed by Sergei Kontsevoy. It consists of the possibility of removing any segment of middle intestine. Such a resection gives more guarantees for adequate outcome. But still there is a lot of room for improvement and development in this area. Now that all the speakers have joined us, I'd like to give the floor to Linda Rabinik. It's not the first time in Moscow for her. Last year, as far as I know, she spoke 2 times in Russia at least on these issues, and she is the most experienced person in organizing screening. She has a lot of experience, and we hope indeed that we will be able to draw some conclusions about how to implement the colorectal cancer screening methods in Russia. Now it is a topical issue for us because we now have launched our national health program that includes a program focusing on cancers. The presentation that will be given by Linda will allow us to better understand that experience and take it into account. Linda, you have the floor.
To start your lecture.
Thank you very much. Thank you very much. Can you hear me?
Push the button.
Can you hear me now? Good. So, thank you very much. And I regret that I cannot speak Russian. I'm very sorry. But it's a tremendous privilege to be here and to be participant in this session. And what I'd like to do is start off and talk about colorectal cancer screening, some background information and some principles. So we know that colorectal cancer is a global public health issue. It is estimated that 2 years ago there were 1.8 million new cases across the world and nearly 900,000 deaths, and obviously even now in 2020, even more. So it's a global public health issue. And this map shows us the incidence in men. So this is number of new cases per 100,000 men, and you can see the dark areas have the highest burden of disease. And here in the Americas, you can see a little dot, that's Barbados, and then in South America, you see Uruguay, have the highest. And you can see a lot of Western Europe, and then you can see Japan, South Korea, Singapore, Australia, and New Zealand. They have the highest burden of disease in men. You can see in this part of the world, it's high, not the highest, but the second highest, and I'm going to show you in a minute that it's increasing. So that is for men, and here you can see for women, and unfortunately in Canada we have among the highest burden of disease in Canadian women. Again, you see Uruguay, Western Europe, Japan, South Korea, Australia, New Zealand. So they have the highest burden of disease, but again you can see in women in Russia, the rates are pretty high and they are increasing. Here is to make that point. This is the Russian Federation, and you can see that in blue, that's incidence in men and in women, and you can see mortality, deaths, in the red in men and women, and both incidence and mortality are increasing in Russia. You see the arrow there. there's a rule of thumb that when the incidence reaches 30 per 100,000, we should be screening. So that you can see that in this country, and we know there's a big push to start screening because the incidence is rising, and it's 30 per 100,000. Now, as for screening, the target age group is 50 to 74 years old, men and women, people with no symptoms of the disease. And in most countries, it's the fecal immunochemical test, or FIT, a stool test that's done at home, and it's repeated every 2 years. And for people who have a positive FIT, then it's colonoscopy that's recommended. And there's a picture of a FIT. There are different manufacturers, but this is just one example. So why is the FIT test so promising? Is because you only have to do it once. There are no dietary restrictions. And it can be quantitated so that it detects the level of hemoglobin in the stool. And a country that has a screening program can determine what the cutoff should be for a positive test. So you can make it a high cutoff, or you can make it a low cutoff, and so you can tailor the definition of a positive test to the amount of colonoscopy that you have. So that's a very positive thing, that's a very good thing, and it is read in a machine. It doesn't have to be read manually, but it's read in the machine. Because of these features, the participation with the fecal immunochemical test is higher than it is for the older stool test, and so it is the recommended stool test internationally. Now, many people say, well, shouldn't we doing colonoscopy? And here's the point that we want to make. If you look colonoscopies, 100,000. So if you were going to screen everybody at average risk with colonoscopy, you would do 100,000 colonoscopies. You would detect about 400 cancers and about 10,000 high-risk polyps or advanced adenomas. So that would be the yield if you were to use colonoscopy for the screening test. If you were to use FIT for the screening test, your 100,000 colonoscopies in the FIT positives would yield 8,000 cancers and 45,000 people with a high-risk pre-malignant polyp. And if you were to screen with FIT, you would be screening 1.8 million people as opposed to 100,000 people if you were doing colonoscopy in everybody. So the yield with the FIT is much higher with colonoscopy. And this is why most countries that are implementing screening will start with the FIT test first and use colonoscopy for the positives. A word about organized screening. The World Health Organization has a definition of organized screening. There's a defined target population, invitations to screen to every member in the target age group, 50 to 74, timely access to the screening test, quality assurance of every step in the process, and tracking of outcomes. So you have to have a cancer registry. So this is the definition of an organized screening program. Now, the EU has set forth quality assurance guidelines for screening programs, and these quality parameters are for every step in the process. So the concept then is that screening is not a test, screening is a process, starting with identifying the target population, making sure that everyone in the target population is invited, assessing the risk and making sure they're fit for screening, doing the screening test, notifying the participant of the results, and then recalling them if the test is negative in 2 years, for example. But if the test is positive, follow up, making sure that they have a colonoscopy. So the concept is that screening is a process, not a test, and we have to be able to measure and assure the quality every single step of the way. This is quite a challenge. It's non-trivial. And so you can see at the bottom we have IT system, information technology system. There needs to be a good infrastructure to measure every step of the way. So how long does all this take? It has been likened to building an airport. If you go into an airport, almost every airport is under construction and has been under construction for a decade. I'm not trying to make a joke. It really takes a long time to build a good screening program. And so we should not expect it to happen overnight. How to start? Well, as I mentioned, there's a consensus in the field that when the time the incidence in men and women together reaches 30 per 100,000, we should be screening. And of course, there are other considerations. How healthcare is delivered, how healthcare is funded, organized, and delivered in a country varies across the world. And so the design of a screening program will differ from one country to another depending on what the health system, how the health system is organized, and of course on the resources that are available. So these are important determinants of how the screening program would be designed in a given country. So the way screening is in the US is very different from Canada, is different from the Netherlands, is different from England, and I dare say different from here, but we're all moving forward. It's really important. We have this expression, getting your ducks in a row, and what it really means is in order to move forward with screening, you need key support from Ministry of Health, Department of Health, Minister of Health, because you need public dollars. You need an investment in the screening program of public dollars. So you need good support from the Ministry of Health, and you need good support from all of the various stakeholders, family physicians, oncologists, gastroenterologists, general surgeons, good support. And you need awareness and support of the population because it's public dollars that are invested. So all of these need to be lined up to move forward. It's really important to raise awareness in the population, and one of the best ways to do that is not for us as physicians, but to find some celebrities, sports figures, people in the media, actresses, actors. Ice hockey is very big in Canada, as it is here, and this is Daryl Sittler. He's the former captain of the Toronto Maple Leafs. His wife died of the disease, his wife Wendy Sittler. And he has been very helpful coming out and talking about the importance of getting screened. And he's very powerful, and he's an icon in Canada, and it really helps raise awareness much more than we can do. And so many places in many countries have found public figures that can have this kind of impact to help make the case. The World Health Organization reminds us that before we start screening, it helps to raise awareness, but we should also strengthen the diagnostic services. So colonoscopy quality, and Sergei Kashin has been a real leader in this country, strengthening and showing how to strengthen colonoscopy quality and strengthening treatment. All of this needs to be strengthened and put in place as a foundational before we start screening. And then when we're moving forward with screening, most places will put out guidelines, either adopt guidelines or adapt them or contextualize them, but there'll be guidelines for screening. There'll be a pilot, and Sergey is doing lovely work in Yaroslavl to launch a pilot. There'll be a pilot to test the steps in the process, to see how best it works, and then to make changes if needed, and then to expand to other sites. So that's the concept. In most places, Canada, we started with guidelines, then we did a small pilot, then we made some changes, then we got more funding and broadened it out to expand it to the whole province, for example. So in summary then, just to recap, colorectal cancer is a global public health issue, including in this country. Organized screening is the way that we would all like to move forward. It's a challenge, and some considerations on how to start with a pilot and with strengthening of colonoscopy. And just before I stop, I want to emphasize the World Endoscopy Organization. It's an umbrella group of endoscopy societies, not-for-profit, and we have regular meetings to discuss screening, and the next one coming up is the UEG Week. That will be in Amsterdam in October. It's a one-day meeting. It's open to anybody, and if you send us an email, we'll put you on our email list, and anybody that is interested is welcome to come to the meeting. It's a terrific meeting, and Sergey has presented last year at our meeting in Barcelona a very nice presentation on his work. So, спасибо.
Я думаю, что
I'm sure that many of you have questions to Linda, because we understand that was a brilliant presentation, and we can see that not everything so simple. It's a challenge. We need efforts, and for us this is also apparent. And this experience, which is already published in literature, it shows that it's not so simple. For example, I saw the article in Great Britain. It's so organized, so disciplined country, but still 2 million test systems were distributed, but only 1 million was returned to test. 1 million was thrown in the bucket, in the rubbish bin. Is it rational to use all this? How do you think, can we avoid these losses? How can we make people to come to do these tests? How can we make them go through colonoscopy? Because usually they don't pay money for this. In the majority of countries, this is done on the account of the country's budget. How can we stimulate people? How can we motivate them to do this?
Thank you. It's a great question. The participation in screening varies from country to country. As you mentioned, England, 50%, roughly 53%. In Finland, for example, it's much higher. It's 85% or higher. And it's something about the culture, we think. Our participation rate is about 60%. It's not what it should be. But I think that helping awareness, as we talked, by having someone who's a celebrity come forward is very helpful in terms of just raising awareness and making it kind of the routine. Making it acceptable and raising awareness is really important.
у меня еще один вопрос. А вот
I have one more question. For example, in Canada, you have screening colonoscopy programs. Do they conduct them also using anesthesia? And is it financed by Ministry of Health, or do you do this without anesthesia?
In Ontario, which is the province where I work, it's a mixture. Most colonoscopy is done with conscious sedation, you know, just an injection. But in some places they use propofol, which is more a deep sedation. All of it is covered by the health insurance plan, all of it. But we don't think that the deep sedation is necessarily needed so much. And we are having a discussion now about what would be the guidelines for using deep sedation or propofol, and when can we use something more simple. The reason is that propofol can only be given by anesthetists, anesthesiologists, and it adds to the cost as to the cost of healthcare. So we think we can shift some of that over to just conscious sedation.
Я так не узурпировал возможность.
So only I ask questions. Maybe my colleagues also can ask some questions. Colleagues, please, if you have any questions to Linda, please ask your questions. Because as I understand, we also have other microphones. Maybe audience, maybe people in the audience, you also would like to ask some questions. If you want, please raise your hand and we'll give you the microphone. Linda, I'm happy to see you once again, and I would like I wanted to ask the question after my presentation, but I will ask it now. How long does it take to conduct the pilot project? For example, you make the decision to start the screening till the moment when already in some particular country we make a decision about the national program of screening.
Thank you. The piloting is really important, and there's no standard length of a pilot. In our case, it was 18 months, something like that. But the way to think about pilot is you don't do a pilot to answer the question, should we screen or not? You do a pilot to test the feasibility of your design. And it's to answer the question, have I got the design right, before I make it really big. So test it first. And so you put together, here's the design of our program, and now we're going to test it on a population, but not the whole country. And almost always there needs to be some modification or some change from what you think is the best, and then you try it, and then you learn what changes to make.
Да, пожалуйста.
Please, some other questions? I will ask using your microphone. Thank you very much. You showed impressive figures, how we can save on tests. I mean here FIT test, but how often can we miss colorectal cancer for the same patients, especially the patients with some particular adenomas?
Yes, thank you. So the question is, how good is the FIT? How good is the fecal immunochemical test? And compared with colonoscopy, how many does it miss? Right? That's the question, yes. So I mentioned that with the FIT, you can decide what the cutoff is. So if you make a low cutoff, a low concentration of hemoglobin in the stool, like 10 micrograms of hemoglobin per gram of stool, that's a low cutoff, then you don't need very much blood to have a positive. If you make the cutoff 150 micrograms per gram of stool, you require quite a bit more blood to be there to call it a positive. So the answer is, how many cancers do you miss depends on what you choose as the cutoff. So let's just say a cutoff of 20 micrograms per gram of stool, then the detection of cancers is about 75%. 75% of cancers will be detected, and about 40% or 30% of high-risk polyps. If you want to detect more cancers, you just lower it to 10. And if you lower it to 10, you'll probably detect about 85% of cancers. So the performance depends exactly on where you choose the cutoff, and that's one of the nice things about the FIT, because you can start with a higher cutoff, and then as you see that you have enough colonoscopy for all the positives, then you can improve it, bring it down. And that's what most countries are doing.
С моей точки зрения,
From my point of view, sometimes we forget that the screening program not only includes the definition by immunological tests, but also it can be done, it should be conducted every year. And in the majority of the national program, this should be done. The colonoscopy should be done, even without FIT. So colonoscopy should still be here in the majority of guidelines in the majority of countries. It should be done on a regular basis. That's why here I cannot see any contradictions, and Linda showed us very well that together with this occult blood definition, we can detect cancer more. And this is a significant difference in frequency of detection. And I think this scheme is quite workable, as I understand, because it's clear that we cannot detect all cancers, but we can detect something else. For example, ulcer, colitis, Crohn's disease. These are also precancerous diseases, and very often they need timely diagnostics. Sometimes we detect also benign neoplasmas, so we can remove them, and in this case we will not have development of cancer. You know, and I like this scheme very well as well, the scheme Linda has shown to us. Who else wants to ask questions, or maybe you have some comments on this issue? We have quite a lot of time. You are welcome to do this. Arina. Linda, thank you very much for your presentation. I have a very technical question. You have experience on pilot program implementing, and also then you realize this scale up on population. I understand this includes a pilot project, and also some organization issues. I am interested in criteria of selection of medical organizations which realize this pilot project. So, coming from your experience, what medical organizations should be included in this pilot program? I mean, some criteria. So what criteria did you use when you build up this pilot program, and you define the organizations which could participate in this pilot program?
Yes, thank you. It was really important with the pilot to try and get everybody behind it, everybody to support it. And so we had the oncologists, we had the gastroenterologists, the family physicians, the general surgeons, everybody. We tried to get them to support it and not to argue. It's really important not to argue, because when physicians argue about how it should be done, it's easier for the ministry or the Department of Health not to fund it. You have to get everybody aligned, everybody in agreement, everybody supporting it, and then it's easier to get public funding. So we had all of those professions all behind it and all supporting it. And then we went to the ministry to, get the funding, and we got a small amount of funding to do the pilot. And we reported back on our results, and they were good. And then we got more funding for the big program. But we try and get every physician group behind it.
Если есть
Do you have any further questions? If you have some further questions, please ask. If you don't have any questions, let's thank Linda for this great presentations and for her brilliant answers. Thank you very much. But from my point of view, I can say that we have already started this pilot project. We are already starting, at least for our city, our great city, Moscow. I think many people now here live in Moscow. Mostly here we have Muscovites. And we have already started with our screening program. And first of all, the Ministry of Healthcare should participate. Only in this case we can start further, because the other participants, of course, will join. All these specialists, oncologists, gastroenterologists, proctologists, endoscopists, but the main thing is Ministry of Healthcare. Please, Alexey Viktorovich Veselov, now we give the floor to you. You are the organizer of healthcare system.
Thank you very much. First of all, on behalf of all the Russian community, I'd like to congratulate the Canadian youth team in hockey with their victory in the World Championship. And in the finals, it was Russia against Canada, and in hockey, at least, we were in the finals, but in screening, we are not yet in the quarterfinals even. So we still have to do a lot, and we are happy that the WHO is assisting us in that area. I listened to your presentation on the 16th of June, and I tried to also take into account that presentation in my work and in my speech. First of all, screening is for asymptomatic population, but in Russia, quite often we don't have true screening. Sometimes we have opportunistic screening, that is to say, screening tests are sometimes used in common medical practice. We've had already some experience in implementing colorectal screening. We know that 24 countries of Europe have already implemented screening programs, and the process of screening in some other countries is at the pilot stage. If we consider overall screening performances in Europe, we see that the performance is different. Sometimes screening is focused on the target population older than 60 years of age, sometimes for people younger, and not everywhere FIT tests are used. Sometimes GFOBT is used, but that's already a matter of finance as well. And the results are quite interesting. In the Netherlands, for example, the initial threshold level was 15. But there was a lot of false positive results. So in order for improve the efficiency of the screening program, they had to change that threshold level. So it's very important to establish the initial threshold level based on the test sensitivity. There is also a problem of colorectal cancer after colonoscopy. It was discussed recently in Barcelona. So before starting the mass screening, we need to take into account all of these factors. There are some other models of screening that include not just the FIT test, but also patient stratification by low-risk patients and high-risk patients. This can be one of the factors that would allow to use questioning in screening in order not to miss CRC. Speaking about the work done by the state national Coloproctology Center as a federal center, we are collecting and analyzing statistical data from all over the country, and we have tried to develop criteria and indicators that will allow us to start the pilot screening program. Speaking about support, there is a lot of support, even at the level of the Russian president, because his decree highlights the necessity of reducing CRC deaths, as well as the necessity to develop national anti-cancer programs, including fighting CRC. And of course, I would like to refer to that amazing presentation by Linda. She said that it's very important to identify the target population, the mechanisms of invitation to the screening. It's necessary to ensure timely access, to guarantee quality assurance, and of course to track the results. Because what I understood in Barcelona, indeed, every country has a certain center or a certain organizational committee that collects information about how screening is working in the country. And of course, our main goal was to identify the possibilities of the pilot screening program, as well as the parameters of this program. I would like to stress that Russia has a certain particularity of its coloproctology service development. In the US or in Canada, there are just colorectal surgeons. But in Russia, there is a dedicated service that includes more than 1,000 medical practitioners. There are more than 1,200,000 people that get outpatient care. There are also a lot of hospital beds available, 4,000 beds, and in 2018, for example, 144,000 people received hospital care. And coloproctologists in Russia include diagnosis specialists who use therapeutical methods as well as surgical methods. So the definition of coloproctology is a bit larger. It was important for us to identify the parameters in order to select the Russian regions that could be used in the pilot project. First of all, we counted the number of colonoscopists per 100,000 population, and there was a lot of difference among the Russian regions in terms of that parameter. If we consider the northwestern regions, there are 850 colonoscopists per 100,000 people. At the same time, in some southern regions of Russia, in particular in the Caucasus Federal District, there were only 371 colonoscopists per 100,000 people. In Russia, overall, the share of colonoscopies out of all the endoscopic tests is very low. In a number of regions it's not more than 10%, and on average in our country, colonoscopies represent only 9% of all the endoscopies. Gastroscopy is more widespread than colonoscopy. So if we want to develop a screening program, of course we have to increase the number of colonoscopies done. Another important point is whether the colonoscopies are done on an outpatient basis or in hospital. If we consider the overall number of colonoscopies, it's not the only factor that we need to consider, because it will not really prove us that a particular region of Russia can participate in a screening program. So we calculated the number of outpatient colonoscopies, and the rate is very low. It is only 60% of all the colonoscopies done, and 40% of colonoscopies are done in hospitals for hospitalized patients who receive treatment for some coloproctological or other diseases. The highest percent of outpatient colonoscopies is observed in the far east of Russia. Perhaps it can be explained by the fact that there are 3 serious outpatient clinics there, and they could actually act as pilot medical organizations that could participate in a screening program. Another important point is the dependency is the number of polypectomies done. Linda has shown that if an FIT test is done prior to colonoscopy, there are more adenomas detected. But for us, it was important to understand whether the adenomas are removed if they are identified during the colonoscopy. So we decided to calculate the number of polypectomies per 1,000 colonoscopies per 100,000 population. And the number of those polypectomies during colonoscopy was quite low. And there is no clear procedure for dealing with such patients. Quite often, after a colonoscopy and identification of polyps, patients need to go to hospital to remove the polyp, and that's already surgery. So when we are speaking about CRC screening, we need to remember that polypectomies shall be done during colonoscopies. And I would like to make a small comment regarding the North Caucasus Federal District. The number of cases there per 100,000 people is quite low, but that can be explained by the fact that the population in that federal district is the youngest in Russia. So we need to be careful about these indicators. Maybe we should not take 100,000 people as a scope, but maybe we should consider just adults or people older than a certain age, because that would allow us to get more accurate results. The number of colonoscopies made is still increasing. In 2015, there was less than 500,000 colonoscopies done, and now we see that there is more than 1 million colonoscopies done in our medical organizations. There is also a huge increase in the number of polypectomies done. In 2017, there were less than 60,000 of them done, and now there are 80,000 polypectomies, and I think that this figure will increase every year. We also have an increase of the number of CRCs identified. As we remember from Linda's presentation, there are 8,000 cancers identified per 45,000 adenomas. In Russia, we have 79,000 polypectomies, and this ratio in Russia is 1:1. So the number of polypectomies should be higher. In the national healthcare system, we need to have at least 2.5 million colonoscopies done per year, and the number of polypectomies should be also higher. There should be 7 or 8 colonoscopies per 1 polypectomy, not more, because otherwise those colonoscopies cannot be considered as efficient. We think that the pilot project that we have now developed can be considered as a starting point to enter the program of colorectal cancer screening. Thank you. I think that it is quite useful to see such information. It hasn't yet been published. That's the result of the work of our coloproctology service. So this is the information that we get every year from the chief non-staff coloproctologist of the country, and you see that this is quite relevant information. But I have a question to our speaker. So you think that during the colonoscopy screening, the small adenomas should be removed during that procedure. That's what you are talking about, right? In that case, I would like to learn the opinion of Victor, or of Sergei Kashin, or of Professor Fedorov, who are leaders in endoscopy. What's the situation as of today? What's the attitude of the Russian endoscopy association towards the necessity and the possibility of doing polypectomies during screening colonoscopies? Is the service ready to do it on an outpatient basis? So, Victor, what's your opinion on that? We would be happy to achieve that, but so far we haven't managed to organize this process. In many regions of our country, it is already practiced. That's the case of Rostov-on-Don. During colonoscopy screening, they have the possibility of doing polypectomy. They just managed to agree upon that with the insurance companies. So now they can do polypectomy during screening colonoscopy. There are also many private clinics of Moscow, and not just of Moscow, where they can do polypectomy during colonoscopy. Those endoscopists can do this manipulation during screening. Thank you. Sergey, you are a very experienced person. Everyone knows about your brilliant annual conferences dedicated to endoscopy. So what's the case of the Yaroslavl region, and what's your personal attitude? Is it possible to organize that? You have all the information about the Yaroslavl region. Is your endoscopy regional service ready to remove polyps on an outpatient basis during colonoscopy? Are the regional insurance companies ready to pay for such outpatient manipulations? Will it be beneficial or not in economic terms? Thank you very much for these very relevant questions that you are asking. These are the challenges that not just the endoscopists but also coloproctologists face. Screening colonoscopy actually includes the removal of all the epithelial neoplasms during the procedure. Otherwise, this screening becomes very complex. It's very easy to lose patients if they have to prepare their bowel several times and have to come to the clinic several times. So, of course, when a patient comes, he should expect not just a colonoscopy, but also the removal of polyps. And according to the standards, polyps should be identified in at least 25% of patients screened. What's happening now in our country in that respect? Victor has made a good example of Rostov-on-Don. Of course, this situation depends on how the collaboration with the insurance companies is regulated. As of today, insurance companies are ready to pay for endoscopy and polypectomy only for patients who are in hospital. So this cannot be done on an outpatient basis. Of course, the situation is still developing, and from the 10th of January this year, the Fund of Compulsory Medical Insurance started to pay for such endoscopy on an outpatient basis. But now we are speaking only about the diagnostic procedure. But still, this is a very good basis for starting a colorectal cancer screening program in our country. I think that the role of the main experts in the Ministry of Healthcare and of the Association of Endoscopists and Coloproctologists of Russia is very important. At this organizational stage, they have to explain to the regulatory bodies why they should pay for the screening manipulations. I think that in the Yaroslavl region, we are as close as possible to the launch of the screening project based on FIT test with subsequent colonoscopy. We have a very well-organized endoscopic service. We are now training our doctors in Japan. It is a long-term training program aimed at training the doctors about how to identify GI cancers at an early stage. And I have to say that the performance of the Yaroslavl region is better in that respect to compare with the other regions of Russia. We have a better identification level of stomach cancer and of CRC cancer, even before the screening program will be introduced. So the issues that you are raising are quite important. So I believe that we should work together to move on. Colonoscopy should be part of screening. Thank you. That's very valuable information. Can you give the mic to Professor Fedorov? He is now one of the active participants of development of clinical recommendations regarding adenomas and various neoplasms of the colon. So, are you also discussing this? So that we could start working with insurance companies about that.
So I think that 93% of all detected polyps can be removed, and of course there can be some patients with complications, but it doesn't mean that they should only go to hospitals. We cannot postpone this. We cannot make second visits for them. And from this point of view, only one obstacle we have. We are trying not to ruin anything, but we are trying to consider this issue. Of course, finances are very important. I can say that in one place we have commercial center and also hospital, and patients don't want to be hospitalized even when we offer them. Sometimes resections and dissections can be done, outpatient in practically like in hospital, but patients spend there not so much time, and the whole world lives like this. So in clinical guidelines will go in one direction with the rest of the world. Let's proceed. Sergey, now will you give your presentation? The chairman, Yuri Anatolievich, dear colleagues, my task today at this round table is to speak about what we have to do to increase quality of colonoscopy, to make it more efficient, and to have this a very efficient method of colorectal cancer detection. In Barcelona, we discussed this. I am sorry for this because a lot of slides here in English, because I presented them in Barcelona at the conference, but I would like to speak in details what we have to do and what we have done already. Why is it so essential for us to increase quality of colonoscopy in our country? Because colorectal cancer now is one of the leading cancers in the structure of oncological structure of diseases. It takes the second place after skin cancer. We spoke already about this, that we have unfavorable trend aimed at annual 3% increase of incidence rate of colorectal cancer. And you can see here the differences with other cancers. For example, stomach cancer incidence rate declines every year. And for us, this is a reason to focus on more efficient detection of colorectal cancer and precancerous pathology of the colon. Speaking about the stages of the disease, you can see that in Russia, less than 10% of cancers are detected at the first stage of cancer. With the exception of Japan, 50% of all cancers of gastrointestinal tract is detected at the early stage, at the first stage, and they can really do not so invasive surgeries. And and other countries also drag behind. Only Japan is the exception right now. In Russian Federation, the same as in other countries, we have the problem of skipped, missed neoplasms. You can see 12% miss rate for colorectal adenomas, 18% for non-expert centers, and 10% for expert centers, and 0.26% miss rate for colorectal cancer. Even in the expert centers where we have very good equipment, still there is miss rate during a colonoscopy. And one more reason for work here to increase quality is that in Russia, in Russian Federation, the screening programs, pilot projects, and so these programs, checkups, they don't give significant results as we wish they could give, and as other European programs manifest. And pilot project, screen projects are in compliance with the international programs. But if we speak about other neoplasms, like, for example, epithelial neoplasms, we are only at the early stage. We drag behind our Western European colleagues. It means that existing dispensarization screening programs don't evaluate the main indicators of screening colonoscopy as adenoma detection rate, polyp detection rate, and some other indicators. So these programs are conducted without a quality program of modern colonoscopy. And another problem, which we have already mentioned during our discussion, endoscopy service in Russia is quite well organized, but still there is some place to improve, because 50% of endoscopes are not in compliance with the standards of colonoscopy, fibro equipment. And also we can see disproportion between colonoscopy and upper GI endoscopy, gastrointestinal tract. And this is also this is what differs our country from other European countries, and also from Canada, where 50% of all endoscopic examinations are also examinations of the colon, colonoscopies. And one of the reasons of this disproportion is not popularity of colonoscopy among our experts, absence of conditions to do this examination, also sedation, and we don't have enough training programs for our specialists. So very often our specialists are not well prepared to conduct high efficient colonoscopy and safe colonoscopy, which could be really good for our patients. Secondly, how to measure the quality of colonoscopy. This is also very important because 5 or 6 years ago in Russian Federation nobody spoke about the main standards and criteria of quality of screening colonoscopy. In 2014 in Yaroslavl a group of foreign and Russian specialists association of proctologist program presented new ideas quality of colonoscopy program, and one of the leaders and initiator of the project for Russian Federation is Professor Alexander Lebechi. He is the head of a very large endoscopic center. He's one of the lead of European endoscopy industry. We made decision to conduct testing and questionnaires of centers, Russian centers, about the main indicators of quality of modern endoscopy, which are in all modern guidelines of European endoscopic community and also American community, and they are promoted as the main indicators of evaluation of quality of endoscopy. These are the results which we received in 2016, and we published in 2014, sorry, and we published this data in 2015 in the foreign media. Not a single indicator which is a standard for screening colonoscopy in the recommendations of European Endoscopic Association. Our colonoscopy tracks behind these international standards. Not good enough preparation, because standard split modes only were applied for 1/4 of patients, but European recommendations speak about this split mode for 100% of patients. We also drag behind the standards of total of colonoscopy. Only 60% so CECOM, and also adenoma detection indicators. We had also lower indicators, 18%, but the modern recommendations assume 25% of patients with detected adenomas, not 18% as we have. This data was published in European journal as an article, and the conclusion was like this: quality of colonoscopy in Russia is still suboptimal, both in terms of adenoma detection, and this means that we need to create educational programs, national educational programs, and also implement sedation and also split mode. What measures are needed to improve the quality? We have created the national project with the support of the Association of Coloproctologists of Russian Federation, Russian Endoscopic Association. We also created the program to train physicians. We announced this project in 2016 in Yaroslavl. The group of experts, so-called QACOL experts group, translated and published modern international standards of conducting screening and colonoscopy. Also, we created a QACOL team of experts, and we had 2 international experts and the gastroenterologists, anesthesiologists, endoscopists who conducted trainings, large-scale events in Russian Federation, more than 50 regional conferences, also with broadcasting, with internet broadcasting for our participants. You can see one of the recent Colorectal courses which were conducted in Skolkovo. We started to use trainings and we now work at practical skills for our practitioners, for our specialists to do colonoscopy. Now you can see the videos how these trainings were conducted. We used a lot of simulating trainings and other technologies which could help us to improve quality of training programs. During last year also we organized 4 championship on colonoscopy, and one of these championships it takes place now. And if you want, you can also show your skills and you can win the cup even at this event. So we tried to increase not only popularity of colonoscopy and the screening of colonoscopy, but also to increase the training program popularity. Also, during the World Cup in Russia, we also played at the colonoscopy field, and there the leading foreign and Russian experts participated, also from Japan. And so last year, for the first time in our practice, we had the running program together against colorectal cancer, in order to increase awareness of people about this problem. And also we wanted to communicate that this is important to detect this type of cancer at the early stage. All materials are also at our portal, our site, which we also created to promote these projects to standardize the quality of colonoscopy. This is undertube.ru. So this is our site. And last year also in St. Petersburg, at the Congress, which is organized by the president of our association, Mr. Korolev, we made conclusions of this extensive educational program, and we had preliminary results of Colorectal. So this data was given by Alexander Lepichi from Humanities University. This was an extensive research, 89 endoscopy departments, 189 physicians participated, colonoscopy tests were evaluated. So 3.5 years, this is the period, and within this period quality of colonoscopy increased a lot, especially in the departments which went through special trainings, thanks to the Association of Proctologists in Russia. We evaluated the indicators of adenoma detection, and they became higher in comparison with the previous cases. And please pay attention to this. The situation is changed regarding split preparation. Now, in Russian Federation, more than 70% of endoscopic examinations are conducted using split preparation. All indicators are increased, and also sedation is better, has high quality now. One good example of quality increase is competition which is conducted in our department, Yaroslavl Oncological Hospital, Regional Cancer Hospital. The initiator here is in the audience. She also evaluates quality of colonoscopy twice per year, and the indicator of detection of colon adenoma, and she understands how the department works and each specialist works. But even in one department, you can see a difference in indicators. It means that there is a long way to go, and we can further promote educational programs and increase quality. Now, I would like to sum up with this. Still, we have barriers for increase the number and quality of colonoscopies in Russia. But what is really a challenge for us? This is a full modernization of endoscopic quality and implementation of video system. But the rest is at our disposal. So we are thankful to Linda very much for her education activity. For information she gives, because she has a lot of experience. She gives recommendations. These recommendations are developed by the Committee on Colorectal Cancer, and this is very important for us. I hope that efficient cooperation and collaboration with Committee on Screening of Colorectal Cancer of World Endoscopic Organization will help us to achieve even more results, to build up pilot projects and to increase the efficiency of these pilot programs. Thank you very much for your attention.
Thank you very much indeed. It has been an interesting and bright presentation. I was born in the USSR, so I remember the motto of learning, learning and learning. That's a very well-known phrase by one of the heads of the Soviet state, Vladimir Lenin. And this motto is still with me, and now we have quite a new concept of continuous education, but it's about the same thing. Even in one department, success level may vary. Perhaps it depends on some capacities of different people, or maybe on the equipment level of different doctors' offices. There are many factors that are in this game. So my question is there any difference in the efficiency of colonoscopy done in hospital or on an outpatient basis? Do you have this data? Was this taken into account in the study design? That's the first question. Second, does sedation have any impact on the result of endoscopy? Is there any difference between a private clinic or a public clinic when it comes to colonoscopy? It's very interesting for me because we are showing some data, but it's only data regarding the public state institutions, but we don't have real data regarding the private sector. And as of today, in many regions, there are a lot of private clinics that are doing colonoscopies and other endoscopic procedures. Do you have this information? Yuri, I am very grateful to you for this important comment, because in this work we took into account the kind of patients that are received by doctors. I have shown just one slide from that work, but for a more detailed comment I would like to give the floor to Natalia, my colleague. She is among the audience and she is one of the leaders of our group. She will be able to answer your question better, as she is now summing up the criteria of evaluating this data. She is also working a lot in a private medical center, so she will be able to give you first-hand information and evaluation of this situation. Thank you, Sergey. Can you speak louder, please? Sure. The first thing I'd like to highlight is the following. You asked a question about the impact of sedation. We did study that. Sedation has more impact on the intubation of cecum. The higher the intubation rate, the higher the adenoma detection rate. There was also a question about the difference between outpatients and hospital patients. The highest ADR was in the younger patients, but we were mostly considering the follow-up patients, and in youngest population the ADR was higher. Doctors from our department, I mean from the Yaroslavl Cancer Clinic, also work in some public clinics, and I counted the ADR of these doctors, and I have to say that in a private clinic ADR was higher than in a public hospital. I cannot yet tell you why it is like that, but I just witnessed such a trend. Thank you. Thank you very much. This is very important information. I believe that this division is quite conditional. This morning, a doctor may work in a public clinic, and in the evening he or she may work in a private clinic. So many doctors combine these jobs. There may be some difference explained by the quality of equipment. At the same time, I'm not sure that a private hospital will be ready to invest into some state-of-the-art equipment. Maybe public hospitals even have more opportunities regarding having more modern equipment. 1 year ago, a work was published. That was work dedicated to the Paris assessment methods, and it turned out that one can reach good results using even fiber optics, but that requires certain skills and training. So yes, on the one hand, digital technologies are very good, they work well, and endoscopists who are working in our clinic have to be kings, because we don't have any fiber equipment anymore. We have state-of-the-art equipment, but the main question is how many colonoscopies are done. If there are 10-15 colonoscopies per day, maybe the results will be higher, because the equipment is used with a necessary level of experience. Another important point is the level of preparation of the patient, and that is a very important point. Doctors have to adequately explain to the patient how to prepare the bowel, what diet to follow, and so on. This is also a very important aspect that we will perhaps discuss during some other roundtable. But once again, what I am satisfied with is that we are not on a starting position anymore. Many things have already been done. Training is underway. We're not starting from scratch. We have enough experts. We have some room for development. And we also have the state policy that is contributing to our effort. There is a national project, and we absolutely have to implement it. So it would be ridiculous not to use this beneficial environment that we are currently witnessing in our country. I'm speaking both about the political will on behalf of the government, and of the president and the healthcare organizers, and the necessity to move on faster, because time will not wait. We have all the opportunities available and all the technologies available. Once again, we see that the necessary documents are also being developed. We know where to move, and we understand that we can make a significant contribution to promoting the ideas that were voiced today. So we have to work with the funds, with the regional insurance funds. We can leverage the example of Moscow, because the insurance companies are already paying a day hospital for colonoscopy patients. That includes not just polypectomy, but also some simple surgeries. Take the example of Botkin Hospital. They have thousands of patients who have undergone cholecystectomy in a day hospital. And by the way, I would like to ask Irina, how do you find working in the format of such day hospitals? What's your attitude towards that, taking into account that there is a department that was well equipped for the day hospital polypectomies? How do you consider these developments? Thank you for giving me the floor. I see that most people present here today are people working in the field of city healthcare, and many work just in the public sector, because there is no time to work both in the public and the private sector, and there is no possibility for such people to compare the equipment level of public and private hospitals. The Department of Healthcare of Moscow is now dealing with CRC screening quite actively, and our main goal now is to identify the priority areas for CRC screening. What I am talking about? I know that many people present here today would like to get the answer to the question, when are we going to get the opportunity to work as people are working in the Colorectal Institute or in Yaroslavl region, where fibroscope is not used, when there is the possibility of video screening of the procedure, so that they can do the procedure more accurately. And of course, that will also allow us to do polypectomy during colonoscopy. So the deadlock here is the equipment and the funding, because we are working within the system of compulsory medical insurance that is financed by the country budget. Today, many hospitals have the possibility of choosing to do colonoscopies in a day hospital or in a short stay hospital. And what can polyclinics do? Because they have limited possibility to do polypectomies during colonoscopies. How to make sure that all the polyclinics have the necessary high-level equipment and the trained personnel to do polypectomy during colonoscopy? What's important for such doctors is not to miss neoplasms and have high performances in terms of ADR. As of today, the situation in outpatient clinics is not optimal. And in many clinics, there are no video system, but only fiber systems. In addition, not all the polyclinics have the possibility to do polypectomy using monopolar coagulation, and not everyone is ready to make cold biopsy because they are afraid of complications such as bleeding, and the doctors will not be able to release those patients. So the organizational issues are still very important for organizing when making their choices regarding CRC screening. Today, there are many areas that are developed. Of course, organizational and finance issues are priority issues. In many polyclinics, for example, and in hospitals, there is a deplorable situation with the equipment. There is a need to upgrade the premises and the equipment. As of today, the Department of Healthcare of Moscow is interested in having all the stakeholders willing to participate in the screening program. One of the measures is to create endoscopic expert centers. So far, we don't have the answer to the questions about who will work there and how they will be organized, but we are planning to resolve all that in the upcoming years so that people could improve their work and participate in the CRC screening project. The equipment issue is almost as important as the staff issue. Every one of us has participated in our national program of endoscopy. I think within this program, people had the opportunity to use simulations and to assess their performances. I'm referring to the Quacol program. That program allows us to ensure continuous medical education. The next question is how to apply our knowledge on practice if we don't have the possibility of having a high resolution endoscopic equipment. Thus, we have no possibility of adequate assessment of a neoplasm and removal of a polyp, adenoma, all of that on an outpatient basis. All these issues will be resolved in the current year within the framework of the expert center program that I have already mentioned. We are going to identify the clinics and hospitals who will participate in this project as pilot organizations. Once these pilot organizations are identified, we are going to decide how we will proceed to the CRC screening and what will be the role of outpatient clinics in this screening program. Perhaps people will be referred to expert centers for diagnostic colonoscopy. So please don't be upset, don't be disappointed. Everyone working in the public healthcare sector has certain experience, and we can say what are the advantages and disadvantages of our system, what are the prospects of the CRC screening program. The first doctor the patient meets when he or she comes to a polyclinic is a physician of the city polyclinics, and as of today we see a lot of patients coming to city polyclinics because they hear information about CRC screening from media, from famous people, and they are more willing to make colonoscopy. Speaking about intravenous anesthesia, this is also considered as part of the CRC screening program. So far, anesthesia is not included in the insurance program, but we are considering the possibility to make colonoscopy under sedation as part of the public medicine. It was mentioned that many want to make colonoscopy just a one-day event so that the person could leave the hospital if there are no contraindications. But that should be then introduced in the CRC screening program, or we should give the possibility to hospitals to refer the patients coming for sedated colonoscopy to a day hospital. We just need to be patient. I think that every one of us is interested in working at the same level as our international experts are working. We have all heard the presentation of Linda, who explained how it is done in Canada. Russia, of course, is even bigger than Canada, but still I think Russia could implement a system similar to that existing in Canada. So all the stakeholders, all who are willing to work in endoscopy, should participate in the CRC screening program. I think that in the nearest future we are going to enter the path that will allow us to perform expert-level colonoscopies in an environment and in conditions comfortable to our patients. And one day, perhaps, we are going to catch up with our Western colleagues, and the ADR level that is now between 18 and 26% will reach the level that has been reached in Europe and the US, as well as Canada. Thank you very much. I suggest that you give a round of applause to you because you made a very nice conclusion. I just have to thank our amazing speakers. Their presentations were truly brilliant. I think that all of us got some motivation to continue the ongoing effort. I am convinced that Moscow has a huge financial resource and potential to be in the vanguard. And we are already working on the re-equipment of the Moscow endoscopy service. I am sure that you will achieve this year. I have no doubt about that. Thank you once again for participating in this roundtable.